Hi everyone, and welcome to an exclusive GI cancer podcast brought to you by VJ Oncology. We are very excited to introduce a roundtable discussion on the latest advances in gastrointestinal cancer presented at the ASCO 2021 annual meeting. This session is chaired by Tobias Arkenau from the Sarah Cannon Research Institute UK in London, who is joined by an international panel of leading GI cancer experts. Together, the panel will be discussing the results of key esophageal studies, including Checkmate 648 and Rationale 302, as well as gastric cancer trials, including Keynote 811. In colorectal cancer, the panel examined first-line studies, including DEEPA and Beacon, and maintenance trials, including Panama and Focus 4. The panel also offered their perspectives on the use of Niliri in biliary tract and pancreatic cancers and data on trastuzumab deruxtecan in metastatic colorectal cancer from the Destiny CRC01 trial. I'll now pass you over to the experts for today's GI cancer session with VJ Oncology.
Hi, it's Toby Arkenau here. I'm the medical director of the Sarah Cannon Research Institute in London. I'm a GI oncologist, and I'm really excited to share with you and a team of 5 colleagues around the world the latest updates on GI cancers from ASCO 2021. And first of all, I want to say thank you to VJ Oncology to make this happening. And without any further ado, let me introduce you to Dr. Lizzie Smith. Lizzie Smith is Associate Professor at the University of Cambridge, Addenbrooke's Hospital in the UK, a GI lead, upper GI lead around the world, heavily involved in ERTC and ESMO. Next, very welcome to Deborah Mukherjee. Deborah is also GI oncologist, associate professor at the American University in Beirut, and also heavily involved in GI and GU research. And works with ESMO and collaborates around the world with various different GI oncologists. Natalia Uboha at Wisconsin Medicine Center, associate professor there, leads the early phase 1 program and GI cancers, and was this year discussant of the poster discussions at ASCO, and will share her insight in some of the updates in GI cancer. And Susanna Ulahanen leads the phase 1 center at the University of Oklahoma, and also GI oncologist involved in many early and late stage clinical trials. Kakin is a colleague of mine here in London, oncologist at University College London and HCA. So let me start with probably the most exciting bits, really practice-changing bits. Lizzie, upper GI cancer, squamous cell esophagus, there have been updates, new entry of immunotherapies, 2 relevant studies, Keynote 648 and the Japanese study ESCORT-1. How do you put them into the context of our current practice? How do you see these 2 studies practice changing, or do you see them practice changing?
Thanks for the question, Toby. First of all, I need to own up to not being an associate professor in Cambridge, or I'll get in trouble at work. But thank you. I would like to be possibly in a few years. So squamous cell cancer of the esophagus is a really important global problem. So although we get a lot of adenocarcinoma patients in the UK and the States, globally, by far, squamous is the much more common. And for many years, this was really an orphan disease, no drug development. So it's fantastic to see these trials emerging with efficacy of immune checkpoint blockade for these patients, and also changing the practice of care and helping these patients to live longer. So there were 2 trials with squamous cancers. The first that you mentioned was Checkmate 648. This was a global trial in which patients with previously untreated squamous esophageal cancer, which is advanced and incurable, were randomized to either standard of care chemotherapy plus PD-1 antibody nivolumab, or a third arm with no chemotherapy and doublet immunotherapy, so an anti-CTLA-4 antibody ipilimumab plus nivolumab. So the first readout was for patients treated with chemotherapy plus nivolumab. And it's interesting that the primary endpoint was in patients who were PD-L1 positive using a tumor marker for PD-L1, which was a TPS score. So now, over the past couple of years, we've got used to looking at PD-L1 expression in esophageal cancers, and we're using TPS because we know that that's using the microenvironment as well as the tumor, and it's probably a better marker for success of immunotherapy in these patients. But the readout was really amazing. So patients who were treated with chemotherapy had a survival of about 9 months, which is what we expect. And we added nivolumab, we improved the response rate, the progression-free survival, and the overall survival being 15 months, which was really fantastic. So this is a practice-changing trial for those patients. In the all-comers group, so unselected by the PD-L1 biomarker on the tumor, the advantage was a little less. It was 2.5 months. And you've got to ask the question, was that 2.5 months being driven by the patients who were expressing the PD-L1? So I think there's unanswered questions there. They didn't present the data for the PD-L1 negative patients, and I would like to see that. The other study was an Asian study looking at pembrolizumab. Interestingly, in patients, also a similar patient population, but no 5-FU backbone in the study. And I think that we're all used to using a 5-FU backbone in Europe, also had positive results. So I think that we can see that there is a group of squamous cancers who are sensitive to immune checkpoint blockade. And these patients benefit from using this with chemotherapy. And it's all about, I think, selecting the right group of patients. What we need to see is the CPS scores from the Checkmate 648. So I think it's been indicated that has been not yet been presented. Using TPS, about 50% of patients that it when CPS is used. So I'll be interested to see what the regulatory approvals are.
I know that's a very, very important and good point. My question, of course, we have a choice of two immunotherapy backbones, effectively one IO and one chemo IO. What's your choice? Who gets chemo? Who gets? I'm
going to say if it's a what would you treat your granny with test? I would say I would give the chemotherapy doublet backbone. My concern for the nivolumab and ipilimumab is that although there was a benefit in terms of overall survival, what we see and what we're used to seeing at this stage is if we don't use chemotherapy in these moderately sensitive populations and early progression. So some patients are disadvantaged by using the immune doublet instead of chemotherapy. So there may be, of course, valid reasons for some patients not to use chemotherapy, but I think you would need to have a conversation with those patients about maybe the 25 or 30% of patients who did experience early progression. So if it were me for my patients and the approval, I think there's no approval yet for the immunotherapy doublet, even in the United States, and maybe our colleagues here can comment on that, but certainly the approval is there with chemotherapy, similar to what was seen in the previous study with pembrolizumab. But certainly, both results are good for patients with squamous cancer. So they're very, very happy to see these results evolving.
Natalia, Susanna, any comments from the US? Is that practice changing for you in terms of, what would you, with US approval, it's probably much easier to get than in Europe or the UK?
Like you said, Natalia, I absolutely agree with Lizzie's summary. I think this was a great summary of the study. And we've had some surprising approvals, I think, in the US in adenocarcinomas that were approvals not based on biomarkers. And we know from prior studies, and we know now from the publications that look at subgroup analysis, that these agents do not work that well in patients with lower PD-L1 score. That being said, this is a practice-changing study. And I absolutely agree with Lizzie that for patients who are chemotherapy candidates, chemotherapy plays a role. We need responses, which is why you saw that overlap again, crossover of the curves early on to the treatment of the disease. I think the other question remains what to do with all the second-line studies that were done in patients with, who have not received prior immunotherapy, because I think those are becoming much less relevant. And we really will need to look at combinations with IO past first lines.
Yeah, I think I agree with both of you. the approval right now is with chemo, so that's what we're going to use. But I think, with the data, with immunotherapy alone, I think in those that are high PD-L1 expression, just to pick and choose where you think they can't tolerate chemo, or also when they have very high expression, or there are some patients that really doesn't want chemotherapy. So I think for all those type of patients, I think this is a very good option.
Yeah, I agree. One of the questions, obviously designing clinical trials, second line studies, how do we design them? So Natalia, you said correctly, the second line immunotherapy, there was a study, the Rationale 302, which was also positive against chemo. These become relatively irrelevant if you use upfront IOs. But how do we rescue the IO combos? How do we need to add? We've seen very interesting data on tiragolumab, the TIGIT combos in other tumor types like lung and gynecological cancers. Will that be the second line rescue? Will be, and again, I've seen some data. Some patients become actually extremely sensitive to taxane. So is that the new chemo arm? What's with irinotecan, the drugs we're using as well in this setting? So maybe Kai-Keen.
So it's going to be relevant if we get to talk about Keynote 177, because everyone's talking about maybe beyond Pembro and doublet Nivo-Ipi and chemo. So I think the interesting thing is this, that I absolutely agree with Lizzie and Natalia and Susanna. It is practice changing for the squamous subpopulation. I think that what my concern is that I think that platinum is great, but there'll be a group of patients who maybe have had platinum within 6 months of, carbotaxol or some other chemotherapy in the radical setting with chemo-RT, don't want to give platinum. The IPI bit is important. I really think that CTLA-4 inhibition it kind of fell behind a bit. Everyone was just going for PD-1. But I think there's something about giving CTLA-4 inhibition, the exhausted T cells. And are we missing a trick here that if you give platinum with PD-1, yes, you get your increased response rate. Yes, you get your maybe slightly better PFS, but then you lose a little bit of that duration of response. And we've seen this in some of the Keynote studies in head and neck when they gave kind of chemo Cetux, chemo Pembro, and all those kind of things. And I think that I don't know how you can integrate IPI to rescue those relapsed patients, though there was a nice talk, I think, by Tony Rebus in a kind of education session about using combos to kind of rescue the patients who have relapsed on immunotherapy. So I do worry that we're missing a trick here, and I think TIGIT, GITR, all those combinations really interesting and going to potentially offer patients chemo-free remissions, forever. And wouldn't that be so cool if we could stratify those patients up front?
Well, I think that in particular, TIGIT looks very good in squamous lung cancer, and I believe the early data in esophageal will also be good. And, they're looking at trials already integrating TIGIT into earlier stages of squamous cancer. So in the chemoradiotherapy frame. So I think it will really be about translational research, won't it? Because are the drivers of resistance innate and acquired the same or different according to histology and according to site of disease? So I think really the translational outputs of in particular early phase studies and pre-treatment biopsies will be really important in informing those decisions in future.
I can see everyone nodding their head when you're talking about translational studies. And I just wanted to jump in that you started with the fact that squamous cell esophageal cancer is a big problem in parts of the world where patients don't have access to immunotherapy. So I think in terms of the global oncology view, those translational studies and knowing about the biomarkers and who really will benefit from either immunotherapy combinations or immunotherapy upfront is really where academically we should be trying to put more of our energy, if that's possible.
Yeah, and you're absolutely right. And again, to Lizzie's very early comments, we don't have PD-L1 status, we don't have TMB. We would expect TMB probably much higher than in the adenocarcinoma population. But I think one lesson learned is if you think about the 649 study in adenocarcinoma, where actually ipi-nivo arm was stopped simply because the higher dose of ipi, the top, and Kakin mentioned it probably became a bit out of fashion, the use of ipi-nivo, probably because the ipi dose was too high, too toxic. And so now on 1 milligrams per kilogram ipi and 3 nivo, that kind of regimen, it certainly resulted in better outcome, and patients could receive treatment. So I think very, very interesting data, and certainly a disease. Think about the squamous cell esophageal, where only 50% of patients make it to second line treatment. Yeah. So if we stabilize, rescue them, and offer them really newer treatments, a great opportunity. Let me change gear. Of course, there's another interesting data, which is the Keynote 811. So combining the pembrolizumab, Herceptin, and chemo versus Herceptin chemo, FOLFOX backbone, which kind of was interesting because it got a fast-track FDA approval based on response. What are we making out of this, Lizzie, and then the rest?
I think that we need to ask the Americans to comment on FDA decisions, because sometimes I feel a little bit uncomfortable commenting on the regulatory decisions of other countries' authorities. I'm not sure, having been to EMA, I'm not sure that we could get past EMA in terms of response. But I'm going to say this, there may be the perception that this is a premature decision based on response. But if we look at the data for immune checkpoint blockade in gastroesophageal cancer, response correlates to long-term outcomes. So even look at the long-term follow-up for ATTRACTION-2, which was the first study of nivolumab in chemorefractory gastric cancer. The 12% of patients who responded in that study had a median survival of about 2 years. So there is, we know that there is that correlate between response and long-term outcomes. And, I'll eat my hat if that study is negative, but I'm going to hand it over to the Americans to ask their opinion.
I share some of your sentiment that we've had some surprising approvals recently, but I think out of all of them, this was probably warranted. I mean, it was hard to ignore those waterfall plots, the response rate of over 70% with addition of pembrolizumab. And also now coming after 2 phase 2 trials that showed similar responses, I think is difficult to ignore. And these patients have a lot of need. I mean, this is a huge unmet need. And so I think I am certainly going to start using immunotherapy in first-line setting in my patients with HER2-positive tumors based on these results. But as I said in my discussion of this abstract during ASCO, we do need to wait for overall survival data. We do need more mature data. This was a pre-planned analysis, but only about half of patients were enrolled. I think the pre-planned analysis after about 260 patients. The total study is 650 or so patients. So there's still a lot more data to be collected, but it looks good as far.
I'm interested actually in where this will potentially leave the studies which are looking at just, for example, Mahogany, which are looking at PD-1 and HER2 doublet without chemotherapy, because how high does this set the bar when you've got a response rate of 90% for you to want to offer a chemotherapy-free option? And I think that will be really, hopefully that's a conversation that we'll be able to have in future, but I think that will be really interesting.
And I think the difference between the Mahogany trial, they're looking at in a chemo-free arm, they're looking at very biomarker-specific patient population. Right? They have to be PD-L1 positive and HER2 positive. In Keynote 811, they did not require PD-L1 positivity, but amazingly, 80% of patients or more are still PD-L1 positive. So I think there's questions to be answered, but yes, the study with mirvetuximab is an interesting one to follow.
Yeah, with the Mahogany study, I have several patients on it, and the quality of life is just, can't compare it with the chemo arm. Both drugs are so well tolerated. Patients are really having a good quality of life. So it's going to be a discussion with the patient, looking at the data, looking at quality of life. What are the goals of the patient? I think we're going to get to that. It's really a great time to be an oncologist, right? We have options. It's not, this is it, and we don't have anything else. I think it will be much more personalized and just see what the goals are for each patient.
And we may have to start teasing out things like How long does it take to get to the response, right? All these things will become important. How deep the responses are. Dr. Janjigian did talk about the depth of response in her presentation, something that we actually didn't discuss before in these tumors because the options were so limited. So I agree. I think it's good to have options, and you'll need to learn how to sequence them too.
I did want to jump in there. I recruited quite a few people in the UK for the Keynote 811. And I think in the last meeting, ASCO GI, we said that one of the problems is these people are quite sick and they do need an early response. So I definitely saw extremely good response. I wasn't sure whether it was because I just picked very fit people, because they're PS01 and therefore they were going to do well on chemo. But I really was encouraged by that. And I've got some patients I think must be on pembrolizumab because they've got some minor effect and they're doing great. My concern, as you said, was that it was a read of about 260 patients of actually, I think it's about 800 patients. They've extended the cohort. And if you look at the response rate, it wasn't quite as good as 90. It was 74% versus 50%. The good news, I agree, Natalia, was that when you look at Yelena's study in phase 2, at least it wasn't much worse than that, because often that's what we see, isn't it? You say phase 2, it's amazing. And then in phase 3, it's like 20% less response rate. And I think what's interesting is the PFS was exactly the same. But again, this is what we saw in the squamous population, is the OS is going to pull out later, and you're going to get, I think, as Toby had said, there's an interesting study in lung where second-line docetaxel after first-line pembro, response rates were 22% versus 8% in, I think, Keynote 10. So that's probably what's going to happen, I think, in these first-line pembro studies, that the second-line chemo or even re-challenge of chemo. So some of my patients who had, chemo plus pembro plus Herceptin and then progress and then again then back on chemo, they've had fantastic responses. And I think there's something about that. So in a way, the Americans jump in, they make the bold statement. Sometimes they're absolutely right and they absolutely is great. Sometimes they're not quite there. Then I hate to say the rest of the world do all the translational stuff to catch up with them, but they usually make the right decisions, because that's the way. I mean, and in some ways, it's great that you have those FDA kind of early orphan indications.
I completely agree. The stop and go approach, I think when patients stay on for a very long time, that, that's very compelling.
Okay, great. A really great discussion. And I want to shift gears a bit into colorectal cancer. Although, you see the last 30 minutes, great excitement, really practice-changing treatments in esophageal and gastric cancer. Colorectal cancer has been, for me at least, more looking into biomarkers, a bit more detailed. Some studies we were waiting for, they just probably confirmed what we would have expected in our day-to-day practice. But I think nonetheless, very important that we have them out and confirming what we thought about, and particularly about the RAS wild type BRAF mutant. Deborah, any views on that? And your view on practice changing? What do we need to do? Do we need to do triple regimens up front, or do we do sequential? All these kind of questions, including, of course, the chemo breaks and maintenance questions. So a big, ask for you to summarize your views.
Sure. So I think moving to colorectal cancer, we have less exciting data at ASCO this year. But as you mentioned, we're trying to refine how we use the tools that we have. So the first trial that we saw was a randomized phase 2 the DEEPer study, a randomized phase 2 study from Japan. And that was looking at the question of using triplet therapy upfront, so FOLFOXIRI plus cetuximab or bevacizumab in patients with RAS wild type colorectal cancer in the first line. And this used an interesting endpoint. So we've been talking about depth of response and correlates in immunotherapy, but in chemotherapy, we have this impression that we like our patients to have an early and a deep response to treatment, but we haven't really conclusively proven that this definitely correlates with overall survival. And this trial chose an interesting endpoint of depth of response, and they were looking, and the trial was actually positive. So the arm randomized to FOLFOXIRI plus cetuximab had a deeper response on average, but actually there was no difference in other markers such as overall response rate or resection rate, and no difference in the preliminary data for PFS and overall survival. So the question that was discussed is really, does this change our management? Probably not. The majority of these tumours, as we see in real life, were left-sided tumours. But again, as expected, the patients with right-sided tumours did less well with the addition of cetuximab. So I'm not sure it really changes our clinical practice. I'm not sure if the panel could comment when they would choose to use FOLFOXIRI as a first-line treatment in their patients with colorectal cancer. It's not something that we'd commonly do in all of patients who have RAS wild-type disease. Perhaps I can ask someone to comment on when they would use this triplet treatment, when to intensify chemotherapy. Perhaps the patient that needs a really rapid response, or the patient who you feel has lots of symptoms due to their disease. Perhaps I could ask Kaifin, in which patients are you choosing FOLFOXIRI upfront for in colorectal cancer?
Yeah, thanks for the question. I mean, I think basically there's a question of less is more, and this one is more is not more. So I think that in the end, with now all the targeted potential agents in first and second line, I'm far less keen to give someone upfront FOLFOXIRI, even in a BRAF mutant patient now. Actually, I think that, it depends on the burden. I'm talking about the tumor burden and the patient's fitness and things like that. But even in a really fit patient necessarily, I'm not sure I would rush in. I might give, I standardly give like one cycle of FOLFOX, get all the profiling done, and then add in the chemo plus maybe bevacizumab and or other things on cycle 2 or 3. And no one's ever done a trial of that, but I think it's generally good because it manages the patient expectations and also saves things for later. I do think that all in is useful, and we've shown in the Olivia trial, we've shown in kind of the other studies of, you give a load of chemo and somehow the R0 resection rate doesn't improve. What are we actually trying to do for these patients? So personally, I think that when you say you're giving targeted therapy with FOLFOXIRI Avastin, that is not targeted therapy. That is hedge your bets like hell, okay? And then hopefully you get a bit of response and survival and stability, and then I would de-escalate massively. But I don't know what the other panel thinks. I'm really I don't like. I do give FOLFOXIRI, but I don't give it really upfront on cycle 1 or 2. I try to think about it and then add it in.
I think, unfortunately, often the patients who need the response most are those who are least likely to tolerate it, isn't it? So we do use, I do use FOLFOXIRI for BRAF mutants, depending on the situation. There's a lot of BRAF mutant patients who have bad peritoneal disease and might not tolerate FOLFOXIRI. And I've also used it in RAS mutant patients. We don't have access to bevacizumab in the NHS. So, ultimately, if I did, I might be more comfortable giving them a doublet with bevacizumab. But if we don't have that choice, I think using a triplet is okay for young patients. And sometimes in the neoadjuvant setting, to debulk really horrible tumours to get them to surgery. And sometimes I have before CRS and HIPEC, actually, for BRAF mutant patients. But it's not a standard. I agree. It's not. I would use doublet much, much more frequently than FOLFOXIRI.
That's very good. I was very excited to see I really look forward to see the molecular analysis of the Beacon study. I was somewhat a bit disappointed the way it was presented. I'm not sure. Deborah, any views on this? It was the comparison doublet versus triplet. I thought we left that debate already, but maybe your view on Beacon and the molecular subtype analysis.
So these were patients who had whole transcriptome sequencing of the initial tumor specimen, and we're trying to really tease out which of the patients that really need the triplet. The addition of the triplet therapy, and I think that their conclusion was that they did find certain molecular subtypes, the more immunologically inflamed subtypes, perhaps, which have a benefit. But I think the problem is that the access to these types of whole transcriptome sequencing is going to be limited. I don't know if our colleagues in the US can comment. So. We certainly don't have access to that sort of thing on a clinical basis. Is that something which your patients would have access to divide them as a biomarker into who should have triplet rather than doublet therapy? Perhaps I can ask Natalia.
Yeah, it is not part of the standard of care right now. So no, we would not have that in clinic either.
Yeah. So I think that's probably far off, although it's an aspiration for the future to try and better define those molecular subtypes. So who are really going to benefit from our toxic and expensive combinations of therapies. And I think this is probably something that needs a little bit more work. And some of the circulating biomarker work is looking a lot more interesting, I think, because we know that we have many changes. We have lots of, potentially not the BRAF mutant patients, but the RAS type patients, lots of evolving mutations which are going to be important to detect. So I think my prediction is that the future will be in circulating biomarkers to refine our treatment strategies for colorectal cancer.
Yeah, I must agree. I mean, I would have expected even in analysis like this, we have co-mutations. What are the ones who don't respond at all? What patients, despite having the V600E mutation? I was missing that completely. And it was a bit like bring the triplet regimen back into the game and try to identify. I mean, it's important work. I don't disagree, but I would have probably for NASCO presentation expected a bit more practice relevant. If I'm sitting in my genomics review board, I want to know what is my V600E plus co-mutation X and Y doing, APC, P53. And we know that those patients don't do well, and they progress even on a BRAF cetuximab doublet after 3 to 4 months versus, where the good ones, where the 10 months PFS. So that's something I again, think about this. These are very important translational research studies where lots of tissues is utilized. So hopefully, there's tissue left to do these other analyses. They may have been not that great, but I was a bit more hopeful that we get more analysis. We need to, as you said, in gastric cancer and in colorectal, we need to move on from that field. We have the tools, the toys to molecularly identify colorectal cancer, and I think we really have to move that on. So there were other studies, again, in the oral presentation session, less is more maintenance therapy. And again, Deborah, Susanna, maybe you want to comment on this. Panama, and then Focus. Kakin, you were the MRC UK fellow on Focus. You were funded. This is your career, Focus. So tell us about some of those data and how this is relevant in the context.
So let's start with Focus 4. So first of all, it was a brave endeavor. Okay, I mean, Focus 4 was, yes, funded massively, and I was a fellow for about 18 months with them. I think that I probably learned more about how not to do basket studies from it. And I still learned a lot. So, it got me into the field. And how maybe you just can't do everything all in one go, and you have to regulatory approve everything. And even I think the modal studies struggled, and even in America they struggled to do their thing. But I think that the Focus 4N group was interesting to be presented. I mean, I think that it was a bucket kind of arm because we were trying more to push the BRAF arm, which didn't pull through, the HER2, the all wild type arm. And now there's some really other interesting subarms which will eventually get published, but we changed the design of the study. So I think you've got to think about this. The only analogy I couldn't think about when we were thinking about was that Cairo 3, which even that is not necessarily practice changing. We had this big thing is how much does bevacizumab add to capecitabine? There wasn't a capecitabine in the arm. Would this be like a kind of Cairo 3 without Avastin? It didn't really turn out that way because we completely skewed the types of patients who ended up in the Focus 4N arm. I think what was interesting was, and you've got to remember when you look at Panama versus Focus 4N, the PFS addition, it looks minor because it's like, oh my God, only 4 months. But you've got to remember they had a lot of induction chemo. They had about 16 weeks of induction chemo. But actually it was interesting that there was some difference. Whether it was clinically meaningful, I don't know. And I don't know it's necessary practice changing. But what's the flip side was Cairo 3 kind of said in the responding patients, you should push maintenance, actually, both in Panama and in Focus 4. And it says, actually, you shouldn't. And I like this because it means the responding patients should have a break, a proper break, as in, if you're clever about this, you don't even need to stratify to ctDNA or anything like that. You just say, look, these responding patients are probably going to do well. You can give them a 6, 8, 12-week break. And the ones who need it are the ones who only achieve stabilization. So that's a roundabout way of saying that neither, I think, Panama, which someone else can comment on the Panama trial, because I think, I massively respect Dominic as well, who's kind of my age and feeling his way around. I think that it's a good endeavor. I don't think it's going to practice change. It already kind of tells us what we're going to do in maintenance, but it's good to get those studies out and discuss that oral presentation.
I think it's important because this is a question which, a lot of patients are having quite toxic maintenance treatments. And this is, really the question, is it really doing them any good? And there's a lot of sort of unevidence-based practice which goes on out there, and patients getting a lot of toxicity, particularly with drugs with visible side effects, which affect the patient. So I think this is really important data that to get out there and to get published.
It is important, but I'd like to again ask Susanna and Natalia, because these kind of first-line studies in the NHS, right? We have only access to EGFR. Let's be honest, in the NHS and first line. So we are pushing our patients, on long-term frontline EGFR, maybe with benefit and some, maybe not. And it came up again in Keynote 177, everyone should get access to immunotherapy. Well, not everyone in the world can get access to both first line and second line and on relapse immunotherapy. So I think that this is the difficulty, isn't it? That if you have a really great healthcare system where you have got approval in every line, you can do re-challenge and second line, that's fine because you can think very far ahead of yourself. But if you have limited options, we normally still say, choose the best option in first line, because that's probably the line that is going to give you that benefit in long term, because you don't maybe have access to the re-challenge of EGFR. So again, just want to ask Natalia and Susanna, both in your cholangio field and things, do you have that feel that, because regulatory things get in the way, you can't actually do everything you want to do, that even in the clinic?
In the US, during the treatment of colon cancer, we have access to all of the approved in the US agents, right? Bevacizumab, anti-EGFR agents, Lonsurf. So in our practice at UW, I think we concentrate a lot on sequencing these therapies. We actually have an investigator-initiated trial led by Dr. Demi, who's looking at first-line anti-EGFR, looking at patterns of resistance with circulating markers, and then trying to even reuse anti-EGFR agents down the line, although traditionally everybody started on first-line chemotherapy. So that's not as big of an issue here. And really, my strategy with colon cancer patients is who are not resectable, of course, or not candidates for ablative local regional therapies to deliver, is to expose them to as many therapies as possible and try to sequence them as to my best ability. So some of the maintenance trials, I thought they were interesting because it's always a struggle to keep patients in chemotherapy for a very long time, and people want treatment breaks. And so I thought it was nice to see some of the data that justifies treatment break, because I'm always worried about stopping chemo. And I think I'm biased by the fact that most of my patients are upper GI patients, and we know that stopping chemotherapy in that patient population is probably not the right thing to do. And a lot of patients deteriorate quite rapidly.
Yeah, I completely agree. And I just feel like just looking at my patient population, we see all these young patients, more and more. I have patients that are in the 20s, 30s, 40s, right, with young families and, keep asking they want a chemo break, and so I really feel like this gave, some more meat, right, that we can give them chemo breaks. And I think it's very important. Because these patients, they stay on treatment for years and years and years, and just to balance quality of life versus longevity.
But isn't it a decision that needs to be made on an individual patient level, right? Because I think I think absolutes are that we shouldn't have them, because some patients will want to stay. I have some patients who've been on Volviria and cetuximab for 3 years, and they wouldn't hear of stopping it. whereas for some patients, 3 months of treatment is enough because they don't like to come to the hospital. Even, they maybe have a low disease burden. And I think that, we can, there are so many trials that often you can find evidence to support whatever argument that you want to make, and if a patient's, for me, if a patient's disease is not an immediate threat to their health and they want to have a break, I think we need to be sensible about these things and, really have a shared decision making. But often they do want us to tell them what to do, I think. And I'm comfortable with either approach, I have to say, depending on the patient.
We need to have the honest discussion and debate with the patient. Again, it's so easy to continue the drug and sign the chemo form or press a button, hey, chemo, go on. It is this honest debate, actually, that it doesn't affect, at least, we haven't seen any overall survival benefit of continuing with treatment. So, Susanna, you said correctly, we see increasingly younger patients, and of course, it's our own conscious. We want to keep them alive, keep them on treatment, but really, does this result in better outcome? I think some of the debates, and this was not only in GI, this year's ASCO was about, this less is more. Do we need to have, as well as an oncologist, the responsibility to have these honest discussion about actually continuing on beyond cycle 10 and whatever may not be the right thing to do. And we rather have a strategy to reintroduce you. Probably we learn, and again, the debate, the Optimox studies were, how old are they? 10 years, and it feels a bit like a second revival, like we have been there before. So it's nothing new, actually. We know this, but we just need to implement this. Okay, biliary tree cancers. I found, again, last year, big, obviously, presentations on FGFR and IDH1. And so this year, Natalia went back to chemo. And I think a very relevant question, probably similar to the squamous cell esophageal population. These patients often poorly, they can't tolerate a second-line treatment. We waited pretty much up to just recently for defined second-line treatment. And here we have one presented with Naliri and 5-FU. Your view on this, and are you using it in day-to-day practice already?
So I'm actually planning to use it for one of my patients next week. I thought this was a great study. So for bile duct cancers, first-line treatment remains gemcitabine and cisplatin, so the platinum agent. There's an ongoing phase 3 study, gemcitabine versus gemcis, but the results are not mature, and a lot of our patients will not be a candidate for triple therapy in first line. So then we get to second line. We're all very excited about all of the biomarker-based studies, and we talked about them up to GI ASCO. It's great. However, it's at most 25 to 30% of patients who, in whose tumors we find something. So that leaves 75% of patients to whom we have limited treatment options. And ABC06 was an important trial. It was a phase 3 trial that looked at FOLFOX versus best supportive care. It was a positive trial. The signal was there. It was not numerically, the numbers did not look that great, right? Especially in terms of PFS. And you looked at oxaliplatin after progression on cisplatin. So also, there's two platinum agents. And so I was excited to see this study. This was a phase 2 trial, phase 2B trial, as opposed to phase 3 trial. This was ABC06. If you look at the number of patients, actually, it was almost identical in each arm. There was 80 patients in each arm. But in this study, they actually compared 5-FU alone to 5-FU plus Nal-ERI, similarly to the study, Napoleon 1 study that was done in second-line pancreatic cancer. And it was a positive study, significant improvement in OS, significant improvement in PFS. PFS was a primary endpoint. Of course, you can't compare study to study, but numerically, it looked better than FOLFOX. And I think for me, looking at the response rate, looking at the OS, looking at the fact that we are changing mechanistically one chemo agent, platinum agent to non-platinum agent, makes me more excited about this regimen as a possibility for my patients in second line. I think phase 3 study is going to be tough because it's a rare disease type, and I don't think we'll have it will take years to complete, but this was a great study.
Yeah, I must say, I use actually the really more often, actually, as well in pancreatic cancer. So like these kind of from FOLFOX series first line, completely stop this and do effectively gem Abraxane and then Naleri and then Folfox, if simply from a toxicity point of view. So I think there's a bit of a resurgence of this in biliary cancers now as well. So quite interesting. Anyone, is this practice changing for you, or just I think it's solid enough. It's a phase 2b study. I probably don't need to see a big randomized phase 3 study.
Anyone? It's not FDA approved though.
That's true.
Yeah.
It's not.
I had a question about the Naleri bit. I mean, so, again, Deborah is saying real world. I mean, if we wanted to go cheap as chips, you would give them Folfiri, right? And there was some data around, when the triple negative breast, nab-paclitaxel with Atezo versus why don't we just Taxol, right? And then, what is it? Is it something amazing about life, being a lipid or not? So I just wanted your view, because we don't standardly give. I mean, there are some trials of FOLFIRINOX versus cisgem for neoadjuvant biliary tract, but I think it's a negative. I think it's a negative study. So where is suddenly that let's just go with not only irinotecan, which has, I think, limited evidence. I mean, 5FU, yes, absolutely, limited evidence of irinotecan, but let's go with it. Let's go with a Naleri. I mean, what do you think about that?
I think irinotecan does have activity in this disease based on small studies. It's a pancreatobiliary disease. Again, you bringing up the point will be of FOLFIRINOX and pancreas. We have some overlapping biology and probably sensitivity to chemo. So, this was likely a company-sponsored study, I think, with liposomal irinotecan. I don't know how much benefit liposomal irinotecan provides over irinotecan here. I think there's some preclinical data showing that the tumor has, I know there's preclinical data showing that the tumor has higher exposure to the active ingredient of irinotecan with liposomal disease and maybe less toxicities. But I don't think we will ever have a definitive answer. And I think it is very reasonable to use Folfiri in the countries and communities where access to liposomal irinotecan is limited.
And now, I mean, in pancreas cancer, they have the ongoing trial with switching the irinotecan to the liposomal irinotecan. Not a head-to-head study, but it gives us a signal. We'll see what that ends up being.
Yeah, it's a first-line phase 3 study with gemabraxine. I actually have an investigator in an initial trial sponsored by Ipsen that looks at this combination in first-line gastroesophageal that we opened last year, and I'm very actually impressed by the tolerance of this regimen.
I agree.
So,
I have patients on that trial as well, the phase 3 trial in PANC, and overall, I mean, we are all used to using the Naleri in PANC, so it's easier than a totally new drug to deal with. We know how to treat our patients and what to look for and handle these patients also out in the community. There's a familiarity with the combo.
Susanna, we're ending closely or finishing in the next 10 minutes. Tell us what's for you most exciting new drugs, phase 1, who made it into phase 2? What is the new molecular target in colorectal, upper GI? Your impression, your views.
Yeah, so I was very excited about the CRC, Destiny CRC01. Our breast colleagues are ahead of us. They, got the approval in 2019, and then we have the gastric GE junction approval. Was it December here in 2020, January 2020, and so then now we see the data from colorectal cancer. I thought it was interesting that they did a 3-arm study with looking at HER3 positive or 2 positive ish positive versus 2 positive and 1 positive, just thinking that, this is an antibody drug conjugate. We just lead the drug to the tumor and it's more the chemo and not a targeted pathway. But there was no responses in 2+ or 1+, but all the data was in 3+. Mainly.
That's really interesting because the HER2 low in gastric cancer had a response rate of 24%. So, but isn't that to do with how they're categorized differently, the HER2 status in colorectal versus gastric cancer, right? The actual scoring systems for the proportion of cells that need to be positive are different, aren't they? So I wonder, is that why that reflects that? I didn't know that. It's really interesting. It's a beautiful paper that I was making a presentation of this actually, and that shows, I think it was in maybe CCR a little while ago, that shows the bystander effect of trastuzumab deruxtecan. And you can see the actual topoisomerase inhibitor part diffusing into the tissue, into the non-HER-positive cells, HER2-positive cells. So it's a really interesting drug.
Yeah, and just looking at the waterfall plots, it's just the study is just stunning. And I mean, so they did. They had to be KRAS wild type to go on this study, but with the response rate of more than 45%. I mean, in a heavily pretreated cohort patient population, and an overall survival of more than 15 months. I thought the data was stunning. We'll see, how it goes in later phase, but they are looking further into this. And also the other thing I thought it was interesting. So in breast, they have the lower dose of 5.4, but both in gastric and now in the CRC population, they've chosen the 6.4. And so I thought it was interesting that they are actually going to compare them head to head with the lower dose versus the higher dose, especially in view of the ILD with this drug. I mean, the waterfall plots are amazing. The efficacy is great, but then we have that 10% of ILD. I mean, when we look at the breast data, which is much bigger, but they had about 13% of our ILD.
There were actually grade 5 toxicities in this study, right? Yeah, within gastric cancer, the majority of them were mild ILD.
Yeah, absolutely.
But these were 3 deaths, I believe.
Yeah, 3 deaths, yeah.
I think it's proportional to the duration of time on treatment, the risk of ILD. So it's unfortunately, sadly, by definition, likely to be shorter in gastric cancer.
That's a good point. Although they did see some of them pretty early on, starting quite early.
Yeah, it can happen anytime. That's really the problem. And, but I think lowering the dose is probably a good idea to see if we can get the same efficacy that with, the breast dose that was used. And just using this drug in gastric cancer, I think lowering the dose to 5.4 hopefully will help the tolerability from that standpoint.
It'll be interesting to see the DESTINY-2 results, I think, in the Western population. So I think we're all looking forward to seeing those and seeing whether the efficacy is equivalent to what was seen in the New England Journal paper, which was Asian patients.
Which is, again, another FDA approval in second-line Western population based on that phase 2 data in third-line Asian population.
I don't know how you guys get people on trials because you've got all these approvals.
And it's already on the NCCN guidelines for CRC.
It was approved right around GI-ASC already. I have a patient on who's responding. It's a great drug, but again,
we've got patients coming from all over the country because we put a fair number of patients on that trial, and it's great to use it. So really looking forward to seeing the results.
Anything else, Susanna? Anything from the drug development early phase GI you found particularly interesting?
Yeah, so we talked about pancreas cancer and really a high unmet need there. But I really like that the NRG1 fusion, the zenocutuzumab, the bispecific HER2/3 antibody. So excited to see that data and to see those waterfall plots and the, just this patient population. I think it's overall 0.2% of solid tumors who have this NRG fusion. So, very small population. It's enriched in pancreatic cancer patients who are younger, who have KRAS wild type. So again, a very small population, but the importance of molecular profiling and just finding those patients, the NTRK, this NRG fusion, just remarkable responses, but very few patients who would benefit. But I thought that was probably the one I got most excited about.
The problem is that these NRG1 fusion results sitting in our inboxes for 3 or 4 years, no one is reacting. So we've recently found a breast cancer patient, 3 years, had a big foundation medicine panel or Caris panel. No one has reacted to that. And so by chance, we found the energy, well, it was there, but someone looked at it in our genomics review board. So with patients on now for more than a year, really pretty much no talks and great responses, this being a breast cancer patient. But really interesting data. And I think it just highlights that, pretty much every day we get new targets, and we need to look at our 300 gene panels we use so often, and often, don't understand this, that those big panels have to go through genomics review boards, so at least people understand genetics and the impact of those. So that's really the lesson learned. And then suddenly you find these. We have just in the last 2 weeks found 2 patients with HER3 mutations, which potentially also respond to that drug. And so, wow, here we are. So very interesting.
And also, with this NRG1 fusion, that they find it much more with the RNA-seq rather than the DNA sequencing. And so it's getting more and more complicated,
Absolutely. Good. I think we are over the hour. Any super highlights I forgot to mention to highlight? It has been a great ASCO, although unfortunately the second time virtually. Hopefully next year we see each other and do from VJ's. I guess VJ Oncology will have a nice roundtable the next time, and we're sitting all in one room and have that discussion live. So thank you again for your time this afternoon. Thank you, VJ Oncology, and really looking forward to meet, talk, and exchange these new findings in the very near future. Thank you, guys.
Thank you.
Yeah.
Thank you so much.
Thank you.
Here.
Yeah. Thanks. Bye.
Bye.
Bye-bye.
Bye-bye.
Thank you to our expert panel and to you for listening to this post-ASCO GI cancer session of VJ Oncology. If you have found this podcast useful, please leave a review and subscribe on your favourite podcast app, including Apple and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on Twitter at VJ Oncology to join in the conversation, and visit vjoncology.com for the latest updates in the field.